Good afternoon to all of you, respected chairpersons and my dear friends. First, I would like to thank Dr. Arun once again for inviting me for this talk. Now, in 20 minutes time, as you know, we can't control, we cannot complete even part of supranuclear control systems. So, what is the goal of eye movements? It is to maintain image of the object steady on the retina, that is to macula to preserve the visual acuity. And this is done by various gaze mechanisms. The gaze has to occur to fixate on eccentric object to redirect fovea from one object to another. That is done by the saccadic system. Second is the fixation of the image when the head is moving, where is fixed to the target. That is done by the BOR and optokinetic system. Third, you have to fixate the image when the object is moving either horizontally or anteroposteriorly. That is done by the pursuit system and the vergent system. Now, coming to saccadic system, saccades, as you know, are these rapid eye movements used to redirect fovea from one object to another. It can be voluntary or involuntary saccades. Involuntary saccades are largely reflective saccades. Now, how is a saccade produced? Suppose you want to look from one object to another. Initially, a burst of activity should go to the agonist muscles to move to the eye to the new target. And that is what is called the pulse or the velocity command. And once his eyes is moved on to the new target, it should not recoil back to the primary position because of the pull of the viscoelastic properties of the muscles. So it is kept in the eccentric position. So we need another innovation called the step innovation, that is called the position command. For the horizontal command, the pulse is generated in the PPRF, that is a paramedian frontal reticular formation. For the vertical movements, it saccades, it is the RIMLF, that's the rostral nucleus fasciculus in the midbrain. Now, how is the step produced? Step is calculated from the pulse. You know, the larger the pulse, the larger step is required because when your amplitude is more, the recoil back will be more. The step is proportional to the pulse, and that is calculated by this neural integrator, which calculates the step according to the strength of the pulse. The neural integrator for the horizontal saccades is in the nucleus prepositoris hypoglossi and medial vestibular nucleus. For the vertical saccade is in the interstitial nucleus of Cajal and superior vestibular nucleus. This neural integrator is inherently leaky, and that leakiness is instability is corrected by the flocculus and the paraflocculus. Let us see the control of the anatomy of the saccadic system. It is called brainstem control, cortical control, cerebellar control from the basal ganglia. This is the basic control is in the brainstem. For the horizontal system, it is in the pons. The vertical and total system, it is in the midbrain. As you all know, this particular Maudry Sharma has already told you about the abducing nuclear complex, which supplies ipsilateral abducing lateral rectus. And the abduced interneurons cross to the opposite side and ascend in the MLF to supply the third nerve subnucleus the opposite side, producing gaze deviation to the same side. This is the excitatory burst neuron which is situated in the PPRF, which activate the abducing nucleus. The excitatory burst neurons in the PPRF connected to not only the abducing nucleus, it also goes to the neural integrator for providing the step innovation. Now coming to the vertical saccades, the excitatory burst neurons with the vertical saccades are in the RIMLF. And the step innovation is by the neural integrator for the step is from the INC, that is interstitial nucleus of Cajal. Now let's see you all know the horizontal gaze pulse we have told you. What is the upward gaze pathway? The fibers arise from the RIMLF, go posteriorly through the posterior commissure and supply the ipsilateral and contralateral third nerve subnuclei. Same thing will the opposite side also supply the both sides. So unilateral RML is potentially transient upward gaze palsy. An enduring palsy to occur, the lesion should be in the posterior commissure, which cuts off both the pathways. Now, on the contrary, for the downward gaze pathway, control is ipsilateral. For example, stimulation of one RIMLF produces only downward movement of one eye. So it connected to the ipsilateral third eye nucleus and the contralateral superior oblique fourth eye nucleus. Now, putting this picture explain a little better. RIML connects the ipsilateral rectus and go to the contralateral superior oblique nucleus. Ultimately, both of them convey the same eye because the superior oblique supplies the contralateral superior oblique muscle. So what will happen? The both will contract and the eye will move downward. So ultimately the RIML from the right side produces downward movement of the eye. Just like the PPRF neurons, the vertical EBN not only projects to the third and fourth oculomotor neurons but also projects to the INC to produce the step innervation. Now there is another group of neurons called the Omnipause neurons, which as the term says, omni, it inhibits all neurons. It is situated in the nucleus raphe magnus. What does it do? It sends inhibitor projection to the excitatory bus neurons with the horizontal and vertical saccades. So they inhibit all bus neurons to prevent the saccade. All the time is getting inhibited. When you want to generate a saccade, the opiate neurons are getting inhibited. And this is done by, and then another control is by the superior colliculus, which control the eye movement directly through the PPRF and also through the omnipause neurons. Now, what is the role of this collicular system? It coordinates the discharge of the burst and omnipause neurons because it decides when to turn off the OPN or the omnipause neurons when the saccade is planned and switch on the OPN when the saccade has reached its target, when the saccade is on the target. So the activation of superior colliculus through an inhibitor interneuron, hypothetically in the midbrain latch cell, it inhibits the OPN to produce a saccade. The other group of neurons in the superior colliculus fixation cells, which directly activate the OPN get activated to stop the saccade. That is, so the superior colliculus coordinate with the OPN to initiate or stop the saccade. Now, there are many other control centers in the brain. One is frontal eye field, then the superior colliculus, vestibular, otolith organs, cerebellum, etc. Now, this is the cortical reticular pathway coming down and stimulating the contralateral PPRF. There are many other centers which I will not go into the detail in terms of this thing. This is the common pathway which you know. Then the pathway from the posterior parietal cortex for the visually guided international saccade. Supplementary eye field and prefrontal lobe has got a role in planning the saccade. The other input is from the brain, basal ganglia. The frontal eye field stimulate the caudate nucleus. Caudate nucleus in turn inhibit the substantia nigra reticulata, which again inhibit the superior colliculus. So activation of the caudate nucleus takes away the inhibition of the substantia nigra and superior colliculus and it produces activation of the PPRF. Now the important control is cerebellar control. The three regions of cerebellum are involved in the oculomotor control. Oculomotor vermis and vestigial nucleus. The other is uvula and nodulus and flocculus that is vestibulocerebellum. Now let us this particular part, dorsal vermis and vestigial nucleus, what do they control? The saccadic accuracy. To stop shot exactly at the point of interest. It's not overshoot or it's not undershoot. The other flocculus and paraflocculus stabilizes the neural integrity as told before. So what will happen? The eye cannot be sustained in one position, it drifts back to the primary position. How does the saccadic error correction is produced? So this is part of the vestigial nucleus called the FOR, the vestigial oculomotor region, that activate the PPRF on the opposite side through what is called the hook bundle of Russell. When does this vestigial nucleus get activated? It fires at the onset of the contraversial saccade to the opposite side. It provides a push for the contralateral saccade to move the eye towards the target on the contralateral side. These nucleus also get activated towards the end of the ipsilateral saccade to produce a brake for the ipsilateral saccade. It should not overshoot. So at the end of the saccade, right episteal going to contract, produce activity of the opposite PPRF to produce a brake for the ipsilateral saccades. So when there is a lesion of the vestigial nucleus, what you are going to hit is the opposite stimulation is taken away. The contralateral saccades are hypometric because of the insufficient push. What will happen to the ipsilateral saccades? They also break. So what will happen? Ipsilateral saccades are hypermetric as a result of impaired braking. So when there is a lesion, this vestigial nucleus is inhibited by dorsal vermis. So as told before, when there is a vestigial nucleus lesion, we are going to get an pulsion because the loss of break. Whereas this is inhibited with cerebellar vermis, so what you're going to get is a contrapulsion. The other part is the floccular nodular lobe, which is stabilized integrator. What will happen? Eye cannot be sustained in the eccentric position. Eye drifts back to the primary position, and then again you have to make a fast component, and resulting in a gaze-evoked nystagmus. Then I'll briefly mention about the abnormalities of saccade. Absent saccades, abnormality in the initiation, that is latency, abnormality in the velocity and amplitude, that is slow saccades, abnormality in the accuracy, hypometric and hypermetric saccade, and inappropriate saccade. Absent saccade can occur lesions anywhere in the pathway. If it's a lesion in the abducent nucleus, what are you going to get? Ipsilateral gaze palsy. Not only that, it can occur not only abducent, BPRF lesions and the cortical reticular pathway all can produce that thing. If there is abducent nuclear lesions, you get ipsilateral gaze palsy. Not only that, you get absent vestibulo-ocular reflex and smooth pursuit. Ultimately, these pathways get connected to the final pathway that is abducent nucleus. Same ipsilateral part, this is because the vestibular nucleus is connected with the abducent nucleus. The same ipsilateral gaze palsy will also occur with the PPRF lesions, but the difference between that and the abducent nuclear complex is that in PPRF lesions, there is preserved vestibulo-ocular reflex and smooth pursuit. Same thing will also occur with the contralateral reticular pathway. Here it is similar to PPRF, only thing is that the gaze palsy is to the opposite side. This already told by Dr. Sharma, there's MLF lesion produce INO. Now, all of you know about the adduction failure of the INO on the ipsilateral side, but in the case severe INO, the affected eye may show abduction slowing in addition to adduction slowing. Because the normal abduction also depends upon appropriate inhibition of the antagonistic medial tractus of the same eye, which could be compromised by MLF. Look at the video of this patient. Or look into the left side, right eye is not adducting. See what is happening in the right eye abduction. That's also slow. See, that shows abduction slowing on the same side. Now, 1.5 syndrome, lesion in the PPRF and ipsilateral MLF will produce 1.5 syndrome. Same thing will also occur with lesions of the abducent nuclear complex. Then one of these is the 1.5 syndrome, which already know. The patient is looking to one side, the left eye does not move, right eye also does not move. Looking to the right side, only right eye abduct, left eye does not abduct. So left eye is a total horizontal restriction. On the right eye, only movement possible is adduction. That's called 1.5 syndrome. Now, as far as vertical saccades are concerned, bilateral lesion RAMLF results in loss of all vertical saccades. But here, there is preserved vertical VOR and vertical pursuit because these pathways get connected with the infranuclear directly to the nucleus. Now, upward gaze palsy can occur not only in lesions RAMLF, but also in posterior commation because, as I told you, the fiber pathway go through the posterior commation. In lesions of the posterior commissure, in addition, they can have vertical pursuit, but the vertical VOR is preserved. Now, this is the lesion there in the upward gaze, but I already told you that's the site of lesion upward gaze palsy. Now, downward gaze palsy, as told you before, the control is ipsilateral only. To produce a downward gaze palsy, the lesion has to be bilateral. So, selective loss of downward gaze implies bilateral RMLE. I think skip the video. I'll show the findings here. See, the patient is looking down, both eyes are not coming down. On looking up, the right eye is going up, left eye is not going. So, just like our 1.5 syndrome horizontally, here there is a 1.5 syndrome on looking up and down. This is called the vertical 1.5 syndrome. That is upward gaze palsy with monocular supranuclear paralysis or downward movement of one eye, or it may be just like a patient downward gaze palsy and monocular supranuclear paralysis or upward movement of one eye. But remember that to call a 1.5 syndrome of any kind, you should be sure that that is not due to the infranuclear paralysis by showing that the vertical VOR or Bell's phenomenon should be normal. There is a set of lesion here that will produce upward gaze palsy. and RIMLF on one side will produce ipsilateral downward gaze pulse. That produces Van de Weyck syndrome. Now, coming to the abnormalities initiation, long latency can be due to disease anywhere in the pathway, maybe in the frontal lobe or collicular lesions, spontaneous lesions, baseline lesions, and extreme form is oculomotor apraxia. Impaired initiation also can occur with the baseline lesions. That is due to the pathway which already mentioned. The caudate activation normally takes away the inhibitor superior colliculus, so brainstem ganglion lesions can also produce increase in the latency. Now, abnormality of the velocity and amplitude, the slow saccades. I think all of you must have seen patients slow saccade. The dictum is that if you can see the eyeball moving to either direction, that means it's a slow saccade. It can be due to PPRF lesions, can also occur due to oculomotor nerve lesions, neuromuscular junctions, and muscle disease. If you find a slow saccade with a restricted motion, think of extraocular paralysis. Slow saccades with full range of motion, suspect due to damage to the excitative burst neurons. If it is horizontal, bilateral PPRF, it is vertical, bilateral RIML lesions. But remember that slow saccades can also occur in drowsy, inattentive, and sedated patients. Where do you get too fast a saccade? You cannot make a fast saccade, only by increasing the amplitude. But if you find in a myasthenia, sometimes you find this phenomena. It's a normal velocity saccade stopped in a mid-flight. So for a short duration of the movement, short length of movement, the velocity is fast. That is called a too fast saccade, hypermetric saccade, superfast saccade. Now coming to the pulse dysmetria, where the error correction is at lost, which I already told you done by the dorsal vermis vestigial nucleus lesion. That is the abnormal size of the pulse. Now, this is a case of saccadic hypermetry. You look at the video, the eye overshoots, look to the right and come back. See, this coming back. That is saccadic hypermetria. Then they can name other problem already told is a saccadic ipsipulsion, contrapulsion. So this is the patient with lateral memory syndrome. You see what is happening to the patient. See, the eyes are deviated to the left side. Very difficulty to deviate there to the right side. I am asking you to look to the right side. The eyes are not moving, but easily moving to the left side. So what do you need to suspect? Even suspect a right-sided gaze palsy from the look of it. But it's not actually gaze palsy. These 2 days later, you find that right-ward movement has improved. So it's not a gaze palsy. It's because of the pulsion. The eyes have all been pulsed to the left side. Now, how does it occur in lateral memory syndrome? As told before, the vestigial nucleus here is inhibited stimulating the contralateral PPRF. As told before, the cerebellar vermis produce inhibition of the vestigial nucleus. And there is another pathway from the inferior olivary nucleus which inhibits the cerebellar vermis. So in lateral memory syndrome, when there is a lesion here, that takes away the inhibition of the cerebellar vermis, which get activated, which increases the inhibition of the vestigial nucleus. So what will happen? The contralateral saccade is inhibited. So what will happen? The contralateral saccade is inhibited, the ipsilateral saccade is facilitated, you get a ipsipulsion in lateral memory syndrome. Same thing will also occur with the right side in the contralateral superior pedunculair lesion occurring after crossing. So inferior cerebellar peduncle port is ipsipulsion, superior cerebellar peduncle port is contrapulsion. In bilateral vestigial nucleus port is hypermetric saccade. How to look for saccadic lateral pulsion? As to keep the eye closed, then the eyes, you see the eyes has already been gone back to one direction, it slowly come back to the primary position. That is how you look for the saccadic lateral pulsion. Then lastly, inappropriate saccade, square wave jerks, takes the eyes off the target followed by corrective saccade after an interval, 200 millisecond interval, due to the impairment of fixation mechanism, macro square wave jerk, larger amplitude saccades. Look at this video. See, the eyes transiently go to one direction, come back after an intersaccadic interval. That's a square wave jerk. Macrosaccadic oscillation is phenomena where there is a series of hypermetric saccade with intersaccadic interval. It looks like some more hypermetric, repeat hypermetric saccade either direction. Then ocular photo obscuranus are inappropriate saccades without intersaccadic. I mean, just 10 seconds only. This is the ocular flutter. There is horizontal saccades without intersaccadic interval. If it is multidirectional, you call it obstaculonus. These are due to the problems of the omnipause neurons. I think I will stop here in the interest of time. Thank you for your patient listening.